Welcome to the Cholesterol Wars, Navigating a Shifting Battlefield, a joint continuing medical education program brought to you by the North American Thrombosis Forum and CNCS-CME. Statin therapy is the recommended treatment for lowering low-density lipoprotein cholesterol, also known as LDL-C, and reducing atherosclerotic cardiovascular disease, ASCVD, risk. However, evidence-based and guideline-recommended therapies, including ezetimibe and PCSK9 inhibitors, continue to be underutilized, even among the highest-risk patients. Consequently, an unmitigated burden of cardiovascular risk persists, and more education is urgently needed to address this problem. To that end, we invite you to join us for a virtual series of webinars that discuss some of these key issues in cholesterol management. You are watching Part 1, Identifying Patients Who Would Most Benefit from PCSK9 Inhibitors. This program is designed for physicians, pharmacists, nurse practitioners, physician assistants, nurses, and allied healthcare professionals in the fields of internal medicine, primary care and family medicine, hospital medicine, cardiology, and endocrinology. The learning objectives for Part 1 are listed here.
Hello and welcome to the North American Thrombosis Forum's continuing medical education webinar series, The Cholesterol Wars, Navigating a Shifting Battlefield. In today's session, we'll be discussing how to identify patients who can benefit most from PCSK9 inhibition therapy. I'm Dr. Alan Taylor. I'm the chairman of cardiology at MedStar Heart and Vascular Institute in Washington, D.C. And I also sit on the medical advisory board for the North American Thrombosis Forum, and I'm delighted to be your host today. Before we get started, I have a few general announcements. This program is presented by the North American Thrombosis Forum, or NATF. NATF is a nonprofit organization dedicated to improving the lives of those affected by blood clots and related diseases. Through comprehensive resources and innovative programming, NATF strives to educate patients and healthcare providers about thrombosis and its complications. This program is supported by an educational grant from Amgen. Before we dive in, I wanted to make a few notices. The first is disclosure of financial relationships. You see them here. Mine are shown, which includes being on the Speakers Bureau for Amgen and Aspirion. As we begin to dive in here, though, I would like to briefly speak about why a thrombosis organization would host a program on cholesterol. It's a good question, but I think it makes a lot of sense in 2022. We've come a long way in cardiovascular risk reduction therapies, and the advent of new, intensely lowering LDL therapies has been really a changing moment, a pivot moment, if you will, in managing cardiovascular risk. We know that LDL cholesterol and atherogenic lipoproteins contribute to atherosclerosis, but they also contribute to atherothrombosis through pathways such as endothelial dysfunction, indirectly, or plaque vulnerability. But even more so today, we recognize new particles like lipoprotein (a), not new, but increasingly recognized and with therapies on the horizon to treat it. And as we learn from some therapies, such as PCSK9 inhibition, it can be lipoprotein (a) patients with elevated levels of lipoprotein (a) can benefit greatly from LDL reduction therapies. And so there's a connection point between thrombosis as a consequence of atherosclerosis and lipid reduction. So with that, we'll move on to our presentations. And I'm really pleased to introduce our first speaker, Dr. Jorge Plutsky. Dr. Plutsky is the director of the Vascular Disease Prevention Program and director of preventive cardiology at Brigham and Women's Hospital in Boston, Massachusetts. He's also an associate professor of medicine at Harvard Medical School. Welcome, Jorge.
Thanks, Alan. It's a pleasure to be here with you today and to have a chance to discuss these interesting issues and also discuss them with Anum Saeed as well. I'm going to get started here with my presentation. I do think this is an incredibly important and exciting area of medicine. I mean, the progress we've seen has just been astounding, and I don't think we're yet at a point of realizing all the potential benefits from further and more aggressive LDL lowering, as we'll go through. My disclosures are available to you. They involve consulting and grants as shown. And what we're going to try and do today is talk a little bit about the data that support LDL reduction and PCSK9 inhibitors use in terms of cardiovascular patients, the indications for using those agents for risk reduction, identifying patients that are most likely to benefit, and talk a little bit about the strategy for initiation and approval, which has been a challenge, for so many clinicians that I think may be part of the barriers that we've encountered. So, this is a very powerful slide. It really summarizes a great deal of data over decades that it's sometimes hard, especially for our trainees, to realize just how far we have come and how we used to think about these issues when we were debating if LDL lowering would make a difference. And what you see here is within some of the major landmark trials of LDL lowering before we got to PCSK9 inhibitors, the placebo groups versus the treated groups in these various trials. So here, starting on the far right in secondary prevention, is the landmark 4S trial. People who had on average an LDL of 190 in a prior cardiovascular event randomized to simvastatin versus placebo, and the results were quite impressive and really established that the cholesterol hypothesis was not a hypothesis, but was a clearly demonstrated benefit. And then, of course, we marched forward across different guidelines and additional clinical trials that continued to show benefit, including in primary prevention, as shown in the yellow line. The line is not as steep because the risk is not as high, but clearly the LDL lowering was making an impact on outcomes. And this raised the fundamental question of would this curve continue to go down, or would there be a flattening of it? There had been prior debates that turned out to be erroneous, that there might be harm from further LDL lowering, but it turns out that that was not the case and often reflected other illnesses patients had. But this question about therapeutic intervention with further LDL lowering is where the field stood. There had been suggestion from the statin trials, as shown here, as part of post hoc studies and subgroup analyses, even before you got the PCSK9 inhibitors, that further lowering LDL would further reduce events. So you can look at data from TNT, Jupiter, and prove it, comparing Torva 80 to Prava 40, that further lowering of LDL continued to have benefit on outcomes. But of course, this was post hoc in nature. Now, what really set this field off, and I think is a very powerful argument, and one that I often use in clinic in talking to patients, is the genetic case around LDL lowering as an experiment of nature, not involving any kind of drug therapy, that came from identifying what were the outcomes in people who had a loss of function of PCSK9 for genetic reasons, not because they were on a drug. And what you see on the left in the upper hand side are people who had a variant of in their PCSK9 gene that did not change PCSK9 function. They look like most Americans here in the Dallas Heart Study, with LDL levels on average around 140 to 150. And beneath that, you see the impact of genetic variants in PCSK9, where the PCSK9, as I tell patients, was broken, that it wasn't working. So loss of function of PCSK9, and these individuals had significantly lower LDL levels. And this allowed the question to be asked and considered of, well, so what's wrong with you if you have low LDL levels, and sometimes very low LDL levels for your entire life? And And the answer was, no, these people did not have issues with brain function. They didn't have issues bearing children. They didn't have issues with myopathy, as some patients have raised to me when they feel they're getting myalgias from the statins, that it's the lowering of the LDL that is the problem. No, these individuals with a loss of PCSK9 were completely normal. The one thing that was different about them, not abnormal, was, as seen on the right, is they had a much lower incidence of coronary heart disease and cardiovascular adverse outcomes by having been given this benefit of a loss of PCSK9 function for genetic reasons. And so I think one of the exciting things about this area is the extent to which it lines up the genetics and the therapeutics. So here are the 4 genes associated with familial hypercholesterolemia, and we're very familiar with the LDL receptor defects causing a loss of function in those people having, as heterozygotes, elevated LDL levels and increased cardiovascular risks, homozygotes having very high LDL levels and having very early onset of cardiovascular risk. There are other genes that look just like LDL receptor variants that have familial hypercholesterolemia, but what's so impressive is that people who have a genetic variant where their PCSK9 is overactive, not a loss of function, but a gain of function, as shown here in this bottom row, they look just like they have familial hypercholesterolemia. So in both directions, we see this effect: loss of function, low LDLs, protection against cardiovascular risk, gain of function, increased cardiovascular risk, increased LDL levels that look just like familial hypercholesterolemia. And so this established a very strong genetic rationale for asking, can we confer the benefits seen in these individuals to others? And also very fundamental questions about, well, what was PCSK9 doing? In these pathways that have been so extensively studied and which we've had so much progress in terms of understanding familial hypercholesterolemia, in terms of statin therapy and others. Here it is just laid out: PCSK9 gain of function, individuals with very high LDL levels in the mid 200s, if not higher, loss of function, very low LDL levels, and the conferring of cardiovascular benefit. So we know the LDL receptor goes through many steps in its activity. Here it is going out to the surface of the cell, binding LDL, ApoB containing particles, and pulling those particles into the cell, releasing the cargo, and then returning to the surface for another round of this binding. There are many steps that the LDL receptor is involved with, and we know that genetic defects in the LDL receptor can span all these steps and impacts the extent to which the LDL receptor is actually working, and can impact the extent to which therapies that depend on the LDL receptor are effective in people who have FH. What was so fascinating was now to have a whole nother aspect to these pathways revealed through this identification of PCSK9, the structure shown here on the left. And of course, it's so exciting I had to make the molecule spin around to convey that. So here you see the PCSK9 protein being secreted. It's this hot dog looking little structure depicted here. When it jumps onto the LDL receptor, that LDL receptor, instead of going back up to the surface for another round, gets degraded and doesn't cycle back up for another round. So now the science really makes perfect sense. If your PCSK9 is overactive, you're going to degrade your LDL receptors more extensively. They won't go back up to the surface. If your PCSK9 is defective and it's not around, then those LDL receptors will keep going back up to the surface, and it will result in a lower LDL level because of the fact your LDL receptors are sticking around for longer and are more active. And raise the fundamental question of, could we confer that genetic benefit to people through a therapeutic approach by using a PCSK9 antibody? It turned out that small molecules did not work. You couldn't just use an oral drug, but an antibody could grab onto that PCSK9 as shown here and keep it from associating with the LDL receptor. So 2 of those agents went forward into clinical trials. The Fourier study was with evolocumab, trade name Repatha, 27,564 patients who had established cardiovascular disease. They were on statin therapy because it is the standard of care that we have. Here you see their characteristics at baseline. I find this very helpful in applying this into clinical practice. Very typical kinds of patients that we encounter. 80% had a prior MI shown here in terms of how they qualified. About 13% had peripheral arterial disease. They had the other risk factors that we often see, and randomized to either receive evolocumab or placebo to see what the outcomes would be. And here you see the primary endpoint, a significant reduction in cardiovascular events on top of statin therapy in further lowering LDL using a PCSK9 inhibitor. The study was actually on the short side, and so particularly impressive that there was this improvement in outcome with Fourier. And here's the second trial with alirocumab, the trade name Praluent, the Odyssey trial. Again, very large trial, nearly 19,000 patients randomized to alirocumab versus placebo in patients with established cardiovascular disease. And again, a positive primary outcome in terms of major adverse cardiovascular events. Quite similar to what we saw before in Fourier. Very striking, very convincing. Here they are summed up side by side. So unequivocal evidence that even on top of statin therapy, further LDL lowering could significantly reduce cardiovascular events, and really highlighted, as I'm going to do throughout the talk, in these green boxes, some of the patients who would be appropriate for PCSK9 use, and that would be people who are not achieving the appropriate LDL levels in either setting of secondary or primary prevention, as the label now embraces. So significant reduction. Here you see the baseline LDLs in both those trials around 90, with a major effect on reducing LDL by adding a PCSK9 inhibitor to therapy those patients were getting. Now, one of the questions very relevant in this area was, one could have hypothesized, okay, this is going to work by lowering LDL, but it won't work in people who come into the trial with lower LDL levels. The mean LDL in both the trials was around 90, but that means there were many patients enrolled with even lower LDL levels. And here you see the data from my colleagues, Bob Giuliano, Mark Sabatine, and their colleagues at the TIMI study group published in Lancet, looking at, well, what about people who come in with baseline LDL levels that are either lower or greater than or equal to 70 in terms of the primary endpoint or the secondary endpoint. And here you see that, in fact, the people with lower LDL levels in the subgroup analysis benefited just as much as patients who had the higher LDL levels above 70. And really, I think, has very much influenced practice in this area, with there being this evidence that lower is better. And in fact, based upon Fourier, one could argue that lowest is best in these high-risk individuals. And it's fascinating to see, if you go back to the Brown and Goldstein Nobel Prize lecture from 1985, awarded to them for studying familial hypercholesterolemia and identifying the LDL receptor, they said, based upon their research at that point in 85, that it looked like LDL levels in the range of 25 to 60 might indeed be physiologic for human beings, that we don't need higher LDL levels than that. And in many ways, these PCSK9 inhibitor trials have really supported that. So, here's science filling in as we have continued to advance beyond statins into the fact that, yes, that reducing LDL levels down to these lower ranges did in fact continue to have benefit. And so, again, highlighting patients where this could matter would be those who have recurrent cardiovascular events despite maximal therapy, and that perhaps even lower LDL levels might have additional benefit in such individuals. The European guidelines have fully embraced this, and I just want to highlight this. Guidelines are really based on guiding us, and the European guidelines look for patients who have high cardiovascular risk and to have LDL levels under 70, and those who have very high cardiovascular risk including in primary prevention with established ASCVD or with significant CKD or familial hypercholesterolemia, diabetes, to be really looking for LDL levels 55 or lower, and in individuals who are having recurrent events to be looking for LDL levels that are even lower than that based upon the data that I just showed you. One issue that comes up very often clinically and accounts for a lot of our referrals to lipid clinic is this question of statin intolerance, which is most often manifest as myalgias, whether or not patients have CK changes. In the clinical trials with the statins, that's about 5% of individuals and often not different between the placebo and treated groups, but in the real world, it's encountered more, 15 to 20% perhaps. And if you look at Fourier as an example of this, I just want to highlight that the PCSK9 inhibitors are quite well tolerated and they're easily administered. I have patients in clinic who say, I won't be able to do this, or won't be able to administer it myself. And I point out to them, in the full range of patients from the young and robust to the more elderly, that I've really had no patients not be able to administer it themselves. And you can see here the tolerability is really, really excellent. And so this does highlight another group of patients in whom this may be relevant, patients who are statin intolerant, either because of side effects or because they have had a serious reaction to a statin, independent of whether it's just myalgias, and sometimes independent of whether or not we think that statin intolerance is true or not. We also have some patients who have a very hard time keeping up with pills, and the ability to use an injectable every 2 weeks or every 4 weeks, as can be done with these agents, has often in my patients proven to be helpful in terms of their adherence. Our guidelines haven't completely caught up with the European ones, but you do see integrated into those guidelines here the use of a PCSK9 inhibitor in patients who are not achieving appropriate LDL levels in secondary prevention under 70 and have had problems tolerating a statin, that we have this now fully embraced. As Alan alluded to, one of the very interesting questions that is part of this emerging story about preventing cardiovascular events is the role of lipoprotein a, LP(a). And this has been looked at in the PCSK9 inhibitor trials, and here you see the data from Fourier about individuals who had LP(a) levels below the median or above the median, and in terms of what happened to them in terms of outcome. And on the right is just another way of conveying that. LP(a) under 120 nanomoles per liter or greater than 120, and then the red are people who got treated, and the blue is in placebo. And what you see is that higher LP(a) levels was associated with greater risk, and the suggestion that even the modest effect that PCSK9 inhibitors have on LP(a), roughly about 30%, did seem to be associated with some tempering of that increased risk around LP(a). So let's talk a bit about clinical strategies for using these agents. One of the ones that I think I highlight all the time to my colleagues here at the Brigham and elsewhere is that any earlier experience about getting PCSK9 inhibitors approved has really changed. The approvals are obtainable. It can be done. Use your clinic note as a basis for that PCSK9 inhibitor request about why patients on maximal therapy and is not achieving appropriate LDL levels or has failed statins with the trials. Lay that basis out. And very helpful is to really just look at the label indications for PCSK9 inhibitor and just cite those in your letter. Why their cardiovascular risk is high, including familial hypercholesterolemia, known cardiovascular disease, even evidence for ASCVD on coronary calcium can be used as a rationale in the LDLs you're going after. The statin intolerance, the prior attempts that have been made and why a patient has failed, evidence for ASCVD on prior CT scans or a CT scan for coronary calcium can be very helpful and instrumental. Sometimes we actually have the patient undergo that scan just to make the point, but very often in clinic we look at prior x-rays and prior CT scans and we can see calcium in the aorta, and we then talk about the patient as having ASCVD. It's critical to educate patients about why we're doing this, about the safety, impact on events, have model pens in clinic, which are easily obtainable, to show them just how easy it is to use these agents. And then some tips about how to get through the logistics involved. We always look to try and request what that insurer prefers among the two agents, because that avoids the extra step of having it denied just because they wanted the request for the other agent. And we also find it very helpful to consolidate expertise by having one person in our staff handling these requests. They get quite good quite quickly at how to navigate the process. And if it is denied, I encourage you to appeal, because sometimes that extra step is necessary. People don't realize that there's been a more immediate rejection of the request, but if you appeal, it's granted. And in terms of identifying patients for use and how to summarize really what we've talked about today, PCSK9 binds to the LDL receptor, targets it for destruction. So as seen in the genetics, if you have a loss of PCSK9 function, you have lifelong low LDL levels. It really makes the case for targeting this, given the protection seen with loss of function and the increased risk seen with gain of function genetically, not having anything to do with drugs. And the clinical trials have established that this is in fact the case, because adding PCSK9 inhibitor to statin therapy and PCSK9 inhibitors alone in the patients who can't be on a statin does decrease cardiovascular events in high-risk patients. This is safe and well tolerated, and the patients who are going to benefit from this are those who are not reaching appropriate LDL targets, whether in primary or secondary prevention, those who are having progressive events and who are statin intolerant. So PCSK9 inhibitors are approvable, and our access now is much better than it had been before. I encourage you to pursue this. It's very gratifying to see the impact. I often have patients saying that they've not seen levels that we're seeing in this kind of setting. So with that, I think I'm going to stop there and turn it back over to Alan, and look forward to discussing some of the science.
Yeah. So thanks, Corey. That was really nice, and a beautiful summary of a lot of great formative evidence on the rationale for PCSK9, and then bringing forward the clinical science in light of the current guidelines, which clearly have evolved and challenge us to achieve lower LDL for our atherothrombotic risk patients. So let's move to a real-world case, and that I always appreciate cases because they both will illuminate what Dr. Plutsky has taught us, and also show some of the practical aspects of decision-making in the clinical setting. Now, a practical evaluation of the use of PCSK9 inhibition, and it's my pleasure to introduce Dr. Anum Saeed. Dr. Saeed is a lipidologist and a non-invasive preventive cardiologist affiliated with the University of Pittsburgh Medical Center Presbyterian Hospital, and she's also an assistant professor of medicine at University of Pittsburgh School of Medicine. And she'll be providing us with a case discussion of a 42-year-old female with hyperlipidemia. Welcome.
Thank you, Dr. Taylor and Dr. Plutsky. That was an excellent didactics talk. I do want to follow up with what remains the holy grail of how do we get these patients, how do we identify and then get the PCSK9 inhibitor therapy to them. So this is a real world case. I do not have any financial disclosures relevant to this talk apart from the honorarium, and there are no discussion of a non-FDA approved medication in this talk. Here's the learning objectives, which really pertain to assessing the indications of the use of PCSK9 inhibitors for cardiovascular risk reduction in a patient who has not achieved lipid level goals. Recognize which patients are most likely to benefit from the addition of PCSK9 therapy to treatment regimen through the lens of both primary and secondary prevention of ASCVD events. And I'd like to discuss initiation of PCSK9 therapy in patients with cardiovascular risk who are not at LDL cholesterol goals while taking patient values and preferences into consideration and applying that information to the case that we'll discuss today. So here's the history of presenting complaint of this individual that I'll be talking about. This is a 42-year-old white woman with hypertension who was seen in the preventive cardiology clinic for the first time. She was seeking consultation for hyperlipidemia management. Her most recent lipid profile showed an elevated LDL cholesterol of 198 milligrams per deciliter, which is untreated. She told the provider about 4 years ago she was initiated on simvastatin, but had to stop taking the medication because of adverse side effects, which manifested as severe myalgias, which she complained. She did not recall any dosing of the therapy at that time that was provided to her, and stated that her myalgias promptly resolved after the cessation of the statin therapy 4 years ago. Currently, she did not take any medication and only took over-the-counter multivitamin supplements. This is her relevant past medical history, which includes hypertension, GERD, and iron deficiency anemia. She also has a history of preeclampsia, which progressed to eclampsia and delivered her twins at 32 weeks 10 years ago. Her family history is relevant here, with her father having myocardial infarction, or MI, at the age of 46 years and a history of high cholesterol. She also has a twin sister with elevated total cholesterol and LDL cholesterol, which was diagnosed in her early 30s. She's an ex-smoker, and she doesn't use any drugs and has a social alcohol use and no binge history. She's quite active and enjoys exercising on her Peloton for bike 4 times a week. Her physical exam is really unremarkable, apart from the fact that she had triceps tendon xanthomas that were present on palpation of her tricep tendons. And these were the labs that we got on her, she sort of brought forward with her, which showed a total cholesterol of 282 milligrams per deciliter, with a triglycerides of 188 milligrams per deciliter, and noticeably a low HDL cholesterol of 46 and LDL cholesterol of 198 milligrams per deciliter. We also checked her baseline hsCRP, TSH, and LFTs, which were all normal, as was the urine analysis, without any evidence of proteinuria, and a vitamin D level, which were all normal. She had an Lp(a) level of 198 nanograms per deciliter, 191 nanograms per deciliter, sorry. She was started in our clinic on atorvastatin 20 milligrams daily and had a recurrence of severe myalgias, which she stated approximately a week after initiation of atorvastatin. We checked a CPK level that was normal, and she was rechallenged with a lower dose and lesser frequency of atorvastatin. However, she had recurrent symptoms. She finally tolerated rosuvastatin 5 milligrams 3 times per week without any symptoms. Her follow-up lab work after 4 months of being on rosuvastatin 5 milligrams 3 times a week showed an LDL cholesterol of 140 milligrams per deciliter. And at that time, a coronary artery calcium score was also obtained, which was 71 and 99 percentile for her age and sex match controls. She declined to titrate any therapy at that time, and stated that she wanted to pursue being on the statin as tolerated, and she would evaluate how she did. And then she was a loss of follow for approximately 2 years with the clinic. She returned to clinic approximately 6 months after being lost of follow for 2 years, and at that time she had unfortunately suffered from her first myocardial infarction at age 43. She was now status post coronary intervention with a drug-eluting stent to her proximal LAD, and that is the left anterior descending coronary artery. Her exam on her return visit to the clinic was unremarkable. Obviously, again, the tendons and xanthomas were present, and her current medication list now contained dual antiplatelet therapy with aspirin and clopidogrel, metoprolol, losartan, rosuvastatin 5 milligrams 3 times a week, and ezetimibe 10 milligrams per daily. That was started upon discharge 6 months ago. Her most recent labs showed an LDL cholesterol of 120 milligrams per deciliter, and a total cholesterol of 188, and noticeably an HDL cholesterol, which was 39 milligrams per deciliter. Understandably, she was quite worried about her health on this subsequent visit to us, saying that the heart attack was like an eye-opener, and she wanted to discuss the residual risk of cardiovascular disease events and how to reduce this risk further. So at this time, PCSK9 therapy was started, and I wanted to highlight the key points here in terms of the same case where we saw that a patient like hers, as outlined by the ACC/AHA 2018 cholesterol guidelines, that in patients with severe primary hypercholesterolemia who have an LDL cholesterol of 190 milligrams and over, without calculation of the 10-year risk, the ASCVD 10-year risk, we can begin high-intensity statin therapy. And if the LDL cholesterol levels remain over 100 milligrams, adding ezetimibe is the potential next step. And the following that, the next step would be to add a PCSK9 inhibitor if they still do not meet that goal. This was tried in this patient. At that time, she decided not to pursue with any intensification of her therapy, and then she proceeded to ultimately have a myocardial infarction event, following which she saw us and her LDL cholesterol was 120 milligrams per deciliter. From a secondary prevention of ASCVD event standpoint, as per the American guideline, the ACC and AHA 2018 guidelines, in very high-risk patients whose LDL cholesterol remains 70 milligrams and over on maximally tolerated statin and therapy and ezetimibe therapy, adding a PCSK9 inhibitor is the next step, which was done in this case. Thank you.
Wonderful, wonderful. Well, let's all come on video and off mute, and we'll have a discussion around some common thoughts that we have. And Jorge, maybe I'll start with you. And really, one question that has come in through the chat, we'll start there, is the idea of selecting subsets of patients for PCSK9 inhibition or augmentation of LDL reduction, and the idea of, are there subsets that tend to benefit even more? And we'll come back to Lp(a) in a moment, but on clinical ASCVD, such as PAD, for example, or recent MI, do you consider all patients with ASCVD the same in terms of benefit from PCSK9 inhibition, or do you think there's classes of patients or subgroups of patients that seem to benefit even more?
Yeah, it's a great question. It comes up all the time. I'm attending right now, have someone covering me for the hour, and so I'm seeing this on a daily, if not hourly basis. I think one of the broad notions here is that it really does vary among different patients, which can be organized into some subgroups, but it can also be patient-specific because we just we can only check what we know to look for. And it does really line up with I think the statin trials, where when the risk is higher, the benefit is greater. And so I think first and foremost, that question had been, will there be benefit in people who have PAD and in patients who have atherosclerotic stroke? And the evidence is there, in particular in the Fourier trial, that it does benefit in patients with PAD. That's been looked at by the Fourier investigators, and it's a separate publication if someone is interested in that. And as we have always known, clinically, those PAD patients do have quite high risk, often because they've not presented with angina. That the real benefit there, which is not necessarily what's going to happen in terms of the limb, but because they often also have coronary disease and are not ambulating, they're not presenting with chest discomfort. And so we've seen that in the statin trials, we see that with the PCSK9 inhibitor trials. Now, one of the things that is provocative is that there was the suggestion in the subgroup of Fourier that did enroll patients, as I showed briefly, this percentage of patients who were enrolled because of PAD, that there may have actually been some greater protection against limb events. Can't be established in this kind of trial, but those patients will benefit, and patients with stroke also appear to benefit with PCSK9 inhibitors. Do they benefit even more? There's lots of things that could factor into that, but I really think it comes down to what is the extent of someone's risk. And that lines up with the idea of someone who has continued to smoke, someone who's not achieving appropriate LDL levels, someone who has established disease. And as the European guidelines point to, those patients we encounter who keep having recurrent events, even though we're throwing everything at them. And that's very hard for any of us, whether internal medicine or cardiologists, to stand on the sidelines and watch someone coming in for another stent, having another event, and everything that they go through and their families go through. And so, yes, I think it does line up with risk, and that looking for those higher risk individuals certainly is a rationale for saying we should be pushing on to better LDL control, especially if you have a patient who's being left with LDL levels that are greater than 70.
Yeah, the goalposts have moved for sure in the guidelines, with really 55 being kind of the new 70, and for super high risk patients being 40 as a goal. And I would agree with you. The PAD patients a real gap. I'm on service this week too here at Georgetown, and just yesterday a patient. The vascular limb service has tons of patients, and they seem to have a lot of opportunities for LDL intensification and a lot of statin use. But we've become sort of monotonic with statins, and this idea of this being really taking a multi-drug approach to optimally control LDL. And as we learned from InterHeart, lipids are really where the greatest population attributable risk does lie.
Yeah. Let me ask you, you see the guidelines in the U.S. catching up with that on this sort of even lower and getting under 55?
Yeah, I think that's a good question. I think they've taken a different approach. With the U.S. guidelines, I think have tried to shift people into action by using a threshold. But I think clinicians are largely goal-directed. Where do I need to get to, and how far away am I? These very low LDL targets now, I think, are going to be. It's interesting to see, but I think they seem to resonate more easily than, say, a threshold idea, in my mind. But I understand the threshold idea because a lot of these new drugs are single doses. You really can't calibrate to a goal. You have to add them. Unlike in the old days when we would titrate statins to get to goal. Yeah. So back to Lp(a), which I find, it seems to amplify the benefit of PCSK9, although it's not the indication for PCSK9 inhibition. It's not labeled for that. It doesn't establish an indication. And so, but it gets to this idea of atherothrombotic risk. So how commonly, Dr. Seed and Dr. Plesky, are you using Lp(a) now as a marker of atherothrombotic risk? And I'll give you a case I saw yesterday. He's in clinic. He's an ASCVD patient. He's 54. He had his first event revascularization in his 30s. He's already on a statin and a PCSK9 inhibitor, but having ongoing problems. His LDL is well controlled, but his Lp(a) remains high at over 200. And so this idea, this residual Lp(a), and trying to find those patients who have heightened atherothrombotic risk. And I know in Dr. Said's case, there was both a familial hyperlipidemia condition, but also elevated Lp(a), sort of a double whammy, if you will. So how are you guys using Lp(a) now to find cases?
Yeah, no, that's a great question, Dr. Taylor. I think the same thing that I showed in my case, which is a real life case. So 35% of individuals, this is based on research, so 35% of individuals who have FH or familial hypercholesterolemia, they have a high Lp(a). Now, we know this better because we've gotten clearly a lot better in detection of Lp(a) and also how we measure it. And still there's some, work to be done there. Clearly, the Brigham's been sort of at the forefront of working on measuring the Lp(a). I really look at it as a big risk enhancer. I think in secondary prevention, it becomes a no-brainer to me. It has been highlighted now, even as far out as the 2018 guidelines. It is a risk enhancer, even in primary prevention when we're looking at statin initiation or PCSK9 inhibition. So the National Lipid Association has gone to the level in the very high-risk patients where the LDL cholesterol threshold to intensify treatment in very high-risk patients is 55 milligrams per deciliter or higher. So in that case, if a patient of mine is coming in, they're hitting 70 but have have this Lp(a) as an additional factor, ultimately that's the one that I'm looking at to initiate PCSK9 inhibitors. PCSK9 inhibition has shown to lower Lp(a) levels, so that's one thing that we have to remember. So a lot of times we deal with insurance having some insurance issues, and how do we get coverage for Lp(a) if the LDL cholesterol goal is like 70 or like 80, that becomes a little bit of an issue. And I think that at that time adding that higher risk enhancing factor of lipoprotein A becomes very relevant as I'm practicing. I check Lp(a) in mostly everyone who comes to my lipid clinic. That's just a practice, just because we know that the range of Lp(a) levels doesn't seem to vary that much throughout lifetime. Again, I think there's more data to come out there, but as far as the American guidelines are concerned, we're a little bit more conservative in checking Lp(a). I think it's indicated by the NLA. Anyone who has premature coronary artery disease, people who have a family history of premature coronary artery disease themselves, you have individuals who have recurrent events like the ones that you just mentioned, or people who have hard to treat LDL cholesterol. So sometimes we're getting these patients who don't have a lowering of LDL cholesterol with either statin or PCSK9 inhibition, and those are the ones that you should be checking Lp(a).
Yeah, interesting. Jorge, how about you? How are you using Lp(a) in your practice?
Yeah, we're certainly screening for it a lot more, and it's fascinating about how often now patients are showing up saying, I've got an elevated Lp(a).
Yeah.
So I fall, very much in line with what Anun said. We're in premature disease, strong family history, and also what I refer to as unattributable risk. The patient who may not be young, but you're like, well, you're normotensive, you don't have diabetes, don't even have prediabetes, you don't smoke. Why are you having a stent placed, or why'd you have an MI, or why'd you have what looks like an atherosclerotic stroke? And then looking for it and often finding it. It's very impressive. Some of these cases are so striking. The last one was in clinic last week of a 47-year-old gentleman who is status post-transplant, cardiac transplant for end-stage atherosclerosis, and it turns out he has a high Lp(a). And so I'm screening a lot more for it, in part because I'm anticipating therapies, and also because it does motivate me to have lower LDL levels and to try and pick up the Lp(a) lowering that can happen with a PCSK9 inhibitor. I will say for the audience, it depends a little bit on the where you practice and what insurance is like. In New England, we cannot often get PCSK9 approved just for Lp(a). It really has to be on the basis of LDL, but we often find ways to work around that because trying to offer the risk reduction that I think exists by making a dent in Lp(a) through a PCSK9 inhibitor. So we're certainly checking a lot more, although not reaching the point of the Europeans of checking in everyone who has an atherosclerotic event, but maybe we'll get there.
Yeah, and if the listeners want to enhance their practice, it's something that often is unchecked, and so you can sort of add that to your clinical toolbox and sort of find something that's been missed along the way. We do have an additional question that's come in, which asks, is there any role for coronary calcium scoring in a patient who's already a candidate for a PCSK9 inhibitor? And I guess because the candidates largely fall under two categories. One is people with known ASCVD, and the second is patients who have FH, inherited hypercholesterolemia, and can be treated. And they're really two separate questions. And I guess with my background in coronary calcium scoring, I could say that the use of coronary calcium scoring in secondary prevention, I think, is a bit controversial because you've already got an established clinical diagnosis on which to base therapy. Although some do still find that calcium scores are predictive, even in that population, although it's not the common way that the test is used. So in general, I would say no, although we need better risk markers and biomarkers of stabilization of disease in secondary prevention. And that's an area where biomarkers, even serologic biomarkers or imaging biomarkers, could come to play in the future. And for the heterozygous FH patient, I would say there would be a role for a calcium score, even if you're a candidate for PCSK9, simply as a way to identify risk and modify your risk assessment. You're still going to have aggressive LDL targets, but in terms of counseling the patient, optimizing other risk factors, and really knowing where they are in their disease trajectory, I think it could serve as useful. But I know with your background in FH, do you use calcium scoring in established FH patients?
It's a conversation with my patients. If they're on some, believe it or not, but some people, even with the 4 times higher risk with FH, having MI and stroke risk, some patients do want to have the objective evidence. So I find coronary calcium as very handy there in terms of convincing them to take medication, and also showing that maybe we need to attempt at a lower LDL cholesterol goal there for their care, subject to them. But my practice traditionally has not been to include that. If the patient already has an LDL cholesterol which is untreated over 190 milligrams with the family history of high cholesterol or coronary artery disease. But if they are on the fence about something and they want to show that they want more evidence to start therapy or improve their lifestyle, I'm all up for it, with the caveat that usually it's about $100, $150 out of pocket payment. As far as the question for secondary prevention, I think I haven't used it much, because I think if you've had an ischemic stroke and now you're technically secondary prevention, all that really we're talking about then is that the process has been started and it's clinically manifesting in one vascular bed, which is the brain. But the likelihood of that process, the atherosclerotic process happening in the coronary bed or the peripheral vasculature, is now also quite high. So at that time, they're already being treated for secondary targets of LDL cholesterol lowering and overall risk prevention strategies.
Yeah. In the time we have left, I wanted to come back to the idea of thrombosis. We're hosted today by North American Thrombosis Forum. And one thing about thrombosis is pure clotting, DVT and pulmonary embolism, for example, clotting and atrial fibrillation. But there's really a tight connection between thrombosis and atherosclerosis, and controlling atherosclerosis is a manner of trying to control prothrombotic risk in the vasculature. And there's this idea, Jorge, about aspirin has fallen out of favor for primary prevention, and I've heard people, and I've even used it, statin is kind of the new aspirin in primary prevention. That controlling lipids is really the way we control risk these days, as opposed to controlling thrombotic risk per se. That we really think about lipid control as almost controlling atherothrombotic risk. We saw MI rates drop by 20% when public smoking bans come in, and I think that's why aspirin's in some way fallen off use. But LDL reduction is really a way to maybe approach this these days. Of course, we're not talking about secondary prevention where aspirin remains indicated. But I wondered if you thought of what is your thinking around this connection between lipid management and thrombosis?
Yeah, the evidence is there for a connection. We've seen that sort of in a variety of different ways, including statins having suggested benefit on thrombosis and recurrent venothrombotic events.
Yes. Rosuvastatin shown to prevent DVT-PE.
Yeah, and then we've also, we've had suggestive studies that say that PCSK9 inhibition may have some benefit. We don't see complications in patients who are getting those treatments in terms of more bleeding, and so there are a lot of subtleties that are involved. The fact is that one can simply say, well, we know that LDL, once it's playing its pathologic role in the arterial wall, is in and of itself prothrombotic. If I lower levels of that, wouldn't I be decreasing sort of a mass effect on potential prothrombotic pathways? I think that's a valid thought. Some of that evidence has occurred from looking at platelet biomarkers and seeing a relationship between that and PCSK9 levels. So I think there is the prospect of that, and does warrant some further consideration. But I think that because the other evidence is there, I think that becomes the focus, particularly in talking with patients, as opposed to having them concerned that they're going to have some kind of problem. And I will say that on the aspirin front, which aligns with NTF's important role in sort of highlighting both the issues related to thrombosis and also atherosclerotic complications, is that the aspirin studies in primary prevention, it wasn't that they didn't show benefit. There were, signals for benefit there. The question was, is it offset by the degree of risk? And so I have a lot of patients who are at higher risk in primary prevention who are tolerating aspirin, have been on it for years, and then, send emails or come into clinic and say, should I stop it now? And, for patients with elevated LP(a), where I think there's a thrombotic component, I'm much more inclined to continue it. Patients who I think who are at risk, who have ASCVD, I'm like on a coronary calcium scan, I'm more inclined to continue it. And I'm excited to keep seeing more evidence around what's the relationship between PCSK9, LDL, and thrombotic risk.
Yeah, we've got as many questions as answers these days. And I agree, there's some subsets, like the subclinical disease one, where in primary prevention, we're still unsure. Although certainly intensification of lipid reduction across the spectrum and, greater attention to statin needs and intensification of multi-drug therapies like PCSK9 inhibitors is really where the guidelines are compelling us and the data is compelling us.
Yeah, I think another, quick comment there that Anun's comments raised for me is the data that someone who has a genetic FH but doesn't have as high an LDL level is at higher risk. And so we have to not lose sight of the fact that these cut points we established, like in that very interesting case that you presented, Anun, of someone with an LDL that was greater than 190, there is a higher likelihood they have FH, but there are people who have FH who have LDL levels of 170 or 180, and presumably their arteries are having a greater area under the curve of exposure throughout their life, and they do have higher risk. And so, you get into this idea of, well, there's someone I'm missing who I could have, should have been more aggressive at.
Well, we're up against the hour, and I wanted to first thank all our participants for coming and learning with us today, and I hope this has enhanced your practice. And secondly, I want to thank our speakers, Dr. Plutsky, Dr. Seed, for bringing your insights and expertise to all of us today. And lastly, thank North American Thrombosis Forum for their advocacy for patients, for science, for best clinical care, and for thinking and for pulling us in new directions and bringing us all together as we think, not in our silos like thrombosis, but in our shared silos, which is patient benefit. So again, thank you all for being here today. I hope you've enjoyed this as I have, and have a great afternoon. Thank you.
Thank you.
Thanks.